Commence with the conclusion. Introduction. Hemostasis can be defined as the process of initiation and termination of blood coagulation with removal of clot as part of vascular remodeling. So it's a protective process that ensures minimal blood loss from sites of vascular injury without compromising the blood supply. The physiologic process results in maintenance of vessel integrity, prevention of further blood loss, and ensuring that blood flow is maintained through the vessel while it's being repaired. Minimizing blood loss does not only help reduce physiologic stress in surgical patients, but helps to increase the viability of tissues and tissue structure. So control of bleeding without compromising tissue integrity is the rule. However, in some situations, if bleeding is life-threatening, few bleeding organs will be sacrificed in the cases of splenectomy. So for the physiology, it occurs in 5 stages, go through the vasoconstriction, platelet plug formation, fibrin clot formation, phagocytosis of the fibrin, and then fibrinolysis. So vasoconstriction is basically as a result of direct vessel injury. So there are neural and chemical substances which are released, which help narrow the damaged vessels, which now leads to the release of vascular substances like thromboxane A2 and thrombin. So it essentially results in two things, which are reduced blood flow to the site of injury, thereby minimizing blood loss, slowing down of blood flow, which allows platelets and clotting factors the opportunity to make contact with the site of injury. For platelet plug formation, it involves the activation of platelets, platelet adhesion, and platelet aggregation. So platelets are activated once they are exposed to soft endothelial collagen via the glycoprotein 1A receptor. Active substances which are already present in the circulation, which will now activate and attract more platelets. And platelets are adhered via the one factor with the 1B, 2B, and 3A complex. Then they now aggregate to form a loose platelet plug, and they also undergo different shape changes, which now exposes the phospholipid surface for coagulation, which will now cause more activation of more platelets. So for fibrin clot formation, it follows the coagulation cascade, which I'll be using this diagram to explain. So the coagulation cascade entails two pathways, the extrinsic and the intrinsic pathway, which then meet in a common pathway. Starting with the extrinsic pathway, this one occurs immediately there's vessel damage, which then causes the release of tissue factor 7, then activated factor 7, which then activates factor 10. Then also in the intrinsic pathway, causes release of factor 12, which is then activated, which then activates factor 11, factor 9, and also activates then factor 8, also then activates factor 10, which is where they now meet in the common pathway. So both the intrinsic and extrinsic pathways lead to the activation of factor 10. So activated factor 10 then, with the help of activated factor 5, converts prothrombin to thrombin, which then converts fibrinogen to fibrin, which at this point bleeding should have stopped. So the pathway is regulated by 3 components: protein C, antithrombin, and tissue factor plasma inhibitors. The cofactor of protein C is protein S, and protein C acts on the factor 5, activated factor 5, and the activated factor 8, whereby it controls overproduction of thrombin and activated factor 8. And antithrombin also acts on thrombin and factor 10 activation. And the tissue factor plasminogen inhibitor acts on them factor 7. So this is just what I explained. So protein C is activated by thrombin to become activated protein C, which then inactivates activated factor 5 and activated factor 8. So antithrombin then degrades activated factors 2, 9, and 10, and the tissue factor pathway inhibitor inhibits factors 7 related activation of those factors 9 and 10 after original initiation. So the next step is now the phagocytosis of fibrin by the reticuloendothelial system, and then fibrinolysis, where plasminogen is converted to plasmin, which then breaks down fibrin, and eventually the clot disappears, dissolves to allow normal blood flow. So these stages I have just explained can each have abnormalities. So I'll be talking about them under platelet disorders and coagulation disorders, which can also be congenital or acquired, quantitative or qualitative. So for the congenital platelet disorders, we have the qualitative ones, which Some examples include the Glanzmann's thrombasthenia, which is a disorder caused by deficiency of platelet integrin alpha 2 beta B, which causes a failure of the adherence of platelets. So the platelets won't be able to adhere in the process of platelet clot formation. Then Bernard-Solé syndrome, also another rare disorder where there's failure of platelet aggregation. It's usually characterized by an unusually large platelet cells, thrombocytopenia with a prolonged bleeding time. Then for the acquired platelet disorders, qualitative examples can be primary and secondary. So primary is idiopathic thrombocytopenic purpura and thrombotic thrombocytopenic purpura. Secondary causes can be use of drugs like sulfonamide, quinine, quinidine, infections like rubella, mumps, HIV, malaria, leishmaniasis, malignancies like leukemias, hypersplenism, bone marrow as a cause of bone marrow irradiation. And qualitative can be due to use of drugs like aspirin and clopidogrel. Aspirin irreversibly inhibits the formation of xan A2, while clopidogrel also irreversibly inhibits formation of congenital clotting factor disorders. They are hemophilias A and B, and they are both autosomal recessive in transmission. And they are basically the deficiencies of factors 8 and 9 respectively. The clinical symptoms depend on the number of clotting factors present in the individual. The activated partial thromboplastin time and clotting time are prolonged, and treatment is usually by the administration of recombinant factor 8 or 9 concentrate or by use of cryoprecipitate. Then von Willebrand's disease is the most common congenital bleeding disorder. It's also by autosomal dominant transmission. Symptoms may include epistaxis, gum bleeding, petechiae, menorrhagia. The bleeding time is prolonged and thrombin time may be prolonged. Treatment can be used by the administration of platelet concentrate, von Willebrand factor enriched factor 8 concentrate, use of desmopressin, and use of cryoprecipitate. So acquired clotting factor disorders due to use of heparin, which decreases the activities of antithrombin, vitamin K deficiency, which causes the lack of vitamin K dependent clotting factors, which are 2, 7, 9, and 10, can be due to obstructive jaundice, malnutrition, liver diseases, warfarin use, and prolonged antibiotic use. Another acquired cause is uremia, which occurs in chronic kidney disease, and it causes the accumulation of guanine-succinic acid and phenolic acids, which results in overstabilization of the platelets. So they can't be activated because they are stabilized. So the treatment is by hemodialysis. Then also by massive blood transfusion using stored blood can also cause that. Then disseminated intravascular coagulopathy is an intravascular activation of coagulation with consumption of the clotting factors. Can be caused by severe trauma, burns, and sepsis. Full blood count will show a picture of anemia with low platelets. The prothrombin time and activated partial thromboplastin time are prolonged, and there's decreased fibrinogen. So I'll just run through types of surgical bleeds. So arterial bleed is a bright red blood spotting as a jet. Venous blood is usually dark, steady with copious flow. Capillary blood is like a bright red ooze, but not as arterial. Primary bleeding occurs during the procedure, that's on the operating table. Reactionary can follow between 24 hours to 3 days after the procedure and be due to stage of ligatures, dislodged clots, high blood pressure. Secondary can occur 7 to 14 days after the procedure. Then there can be internal hemorrhage and external hemorrhage. So for the principles of surgical hemostasis, going through the pre-op, intra-op, and then post-operative approach. So for pre-op, a careful history and physical examination is very important. You note the age of the patient. Do they have any history of bleeding from minor procedures like dental extraction, tonsillectomy, any family history of bleeding disorders, any bleeding episodes, excessive bruising, painful joints, which can point to hematrosis, hematuria, can rule out hepatic and kidney disease, asking for symptoms of jaundice, abdominal swelling, excessive itchiness, early morning facial puffiness, then malignancies, weight loss, loss of appetite, decreased activity. And if they are hypertensive, if they are on some of those drugs that can cause any of those disorders, any of those abnormalities. Then on examination, you do a general physical examination, examine for any of those signs of liver disease or kidney disease, check the skin, the mucous membrane for any purpura, petechiae, ecchymosis, any chronic joint deformities, any limited range of movement in hemophiliacs, any obvious joint swelling and abdominal exam. You can check for hepatosplenomegaly. Then investigations, you can do a full blood count, clotting profile, liver function test, renal function test, and bleeding time, which will point to any abnormalities. Then you can also counsel the patients appropriately, especially for the hemophiliacs. You have to involve specialists, the hematologist, and so proper patient counseling is important. Then you have to stop any anticoagulant the patient is on prior to surgery. You optimize the PCV by pre-op transfusion, nutritional optimization because malnourished patients cannot undergo surgery. Hypertensive patients should ensure they are regular on their antihypertensives, then they can also prepare blood ahead. Intra-op, choice of anesthesia. Local anesthesia is better than regional anesthesia, and regional is better than general in preventing excessive hemorrhage. Then proper positioning is also important. This head up positioning for head and neck surgeries, the minimal positioning for pelvic surgeries. Then the surgical technique, minimal incisions will help. So minimal invasive methods like laparoscopic surgery can also prevent excessive bleeding. Then mechanical means of preventing of controlling hemostasis can be through pressure packing, pressure dressing, bandaging, non-strangulating, use of digital pressure, can use the Pringles maneuver, use of hemostats, like crushing and non-crushing clamps, staples, use of forceps like the artery forceps, use of ligatures, suture ligatures, transvection sutures, balloon tamponades, tourniquets, vintage, then chemical pharmaceutical methods, you can use of fibrin glue, epinephrine, somatostatin analog, oxycel, oxycel gel foam, so bone wax. Then you can also through thermal and electrical, use of diathermy can be monopolar or bipolar, cryosurgery, argon beams, lasers, ultrasonic scalpels, water jet dissectors, ligatures. This is just a picture of the diathermy machine and the harmonics. This is the bipolar and the unipolar diathermy. So post-op, control of blood pressure is very important. Pain management is also important because pain can increase the blood pressure. And we also need to control infections, prevent sepsis, post-operative sepsis, and wound dressing is also very important. So this is just a table showing the mechanical, the thermal, and pharmacological methods that can be used to achieve surgical hemostasis. So complications for pre-op complications, if hemostasis is not assured, it can be caused surgical delays, like patients who might need emergency surgeries and they have conditions that will prevent the surgeries from going on. Then during the surgery can cause excessive primary hemorrhage, can prolong the operation time. Post-op, there's a risk of transfusion reactions if you have to transfuse the patient a lot. Then there can also be excessive reactionary secondary hemorrhages. So for the local experience, we use diathermy, use harmonics and ligatures, bone wax, gel foam, pressure packing, use tourniquets, clamps, forceps, surgical. So in conclusion, the success of any surgical procedure depends on a surgeon's ability to effectively and efficiently manage hemostasis to provide an optimal view of the surgical field and to prevent the adverse physiologic effects associated with blood loss. So mechanical, thermal, and chemical methods are available for managing surgical hemostasis. However, during some procedures, a patient's normal clotting mechanisms may be insufficient or in the use of standard methods, which I've already explained, may be impractical to achieve and maintain adequate hemostasis. So this is where use of topical hemostatic agents may be ordered by the surgeon to assist in the coagulation process. Thank you.